different computer.
Thank you.
All right, we're good. So I want to kind of pick up where Rima left off, which is a wonderful position to be in. But before I start, I just want to say the person who really leads this work at RAND is my junior colleague, Laurie Martin, and it has been wonderful having the pleasure to work with her on this, and that she came to us from working with Rima. So this is a small world that continues to wrap around. Starting with health literacy, I want us to think for a minute about who's affected by health literacy. Ultimately, all individuals can be affected by a mismatch between their literacy skills and the materials that are available. Certainly, some groups are disproportionately affected: the elderly, racial and ethnic minorities, immigrants, and those with limited education. But I think it's very important as we talk to people about understanding health literacy to understand that we're all one diagnosis or one accident or event from being in that situation where the information coming at you is more than you can take in a given situation. And you need to be able to rise to the occasion and learn about an area you've never expected to need to know about and develop some expertise. And that's where this skill set becomes very critical. It's also not only about your reading ability, that's what people usually think of, but numeracy skills in ways even that go beyond what Rima was discussing. Your ability to solve the complex situation of needing to be able to take a medication 3 times a day, either 1 hour before you eat or 2 hours after you eat, and what do you do when that time doesn't exist? And so to be able to problem solve and look up and find the tools around you if you don't have them yourself available. Moreover, health literacy is a critical pathway through which education, income, and other human capital resources, and I'm going to argue community capital resources, affect healthcare quality, disparities, and outcomes. It's important because it's a machine that's driving this problem, and it's one of the rare places where we can get traction across many issues. The complexity arises, however, in that identifying people with low health literacy is challenging and even potentially very stigmatized for the individual. It remains a hidden epidemic. And every time that we don't understand that somebody doesn't make that match between the information that they're being given about whether it's prevention, treatment, or other aspects of health, we're undermining being able to deliver care to them or to be able to address and prevent particular health problems. However, screening is very expensive and time-consuming and not well suited to a healthcare setting. There's even a lack of consensus on how best to screen, and the interventions available are difficult to target to the individual level. Now, the part that I bring to this is I want us to think about how health decisions get made in the first place, and we don't make health decisions or other decisions, frankly, totally in isolation. Decisions tend to get made at the family level. Other decisions that relate to your ability to affect your health are made at the workplace or employer level, the community, and broader social policies. So as people turn to informing and dealing with their health and health care, they rely somewhat on the health literacy of those around them in their social network, friends, family, neighbors, and coworkers. Now, from a constrained choice perspective, and this is an area I've been writing about with my colleague Pat Ricker for many years, the individual is shaped by this array of opportunities, and those opportunities end up having an impact on their ability to pursue a healthy life, if you will. As a result, an individual living where there is this higher resource of community health literacy can be buoyed up and carried forward, advantaged in dealing with the new health situation that's arisen for them, or ongoingly. Example is my neighbor and babysitter who's a Greek immigrant who's lived here for many years and has moderate education. Because she lives in an area of high health literacy, she can turn to people and get very good information that augment and help her deal with different health crises around aging and other concerns. However, the same person, were she living in an area with very low health literacy, it wouldn't mean she wouldn't be turning to people or that they didn't have information, but the information they have would be much more likely to be dated, to be incorrect, to be aiming at solving other kinds of problems, such as how do you balance the expense of your medication with paying your rent, And so people are dealing with different kinds of problems in different ways, and they may not have the information to be able to give her to even help figure out what's a serious symptom, what's a serious problem, how do you deal with it, and what kinds of trade-offs to make. So even in attempting to avoid risk, it may be unsuccessful. So I'm arguing that there's a huge benefit in focusing on communities rather than simply individuals because it provides additional opportunities for action. First and foremost, I'd like for us to be able to be doing mapping and giving information back to communities because it helps communities own the problem. Communities are a key stakeholder in this issue. In so doing, this can become a shared responsibility, whether you're talking about the service area for a medical group or a health plan or the community that an individual lives in. It can also lead to much more efficient resource use, and that can mean a positive return on investment where organizations and groups are attempting to reach out and do interventions to improve health and health care. And the ability to be successful at that and to apply scarce resources effectively is critical. Last but not least, mapping helps identify the communities that actually have low health literacy in ways that we've frequently found were distinctly different than the assumptions that were made from a more shoot from the hip bivariate approach. So to address this problem, RAND, led with Lori Martin and Nicole Lurie was involved at the time, helped build the capacity to map health literacy to small geographic areas. To this end, we developed a predictive model using the health literacy data from the National Survey. And in our model, we incorporated common census variables, and they're also available in the American Community Survey. Age, gender, race, ethnicity, education, income, marital status, other characteristics that are available and in ranges and ways that they are available in this public data. We then applied the model to census data to be able to go back and produce area-level measures that predict particular levels of health literacy and to map hotspots, and provided the link to the tool for those who are interested. Now here's an example showing the percent of the population with above basic health literacy, meaning intermediate or proficient, across an area. And you can see the highlighted dark red areas have particularly low levels of above basic health literacy. And this is important in, I would argue, any kind of intervention you're going in to do public health. So we need to use this information much more widely. It also helps us prioritize hotspots. Now, there's two kinds of hotspots. One is, where is the problem actually going on that an organization or an intervention is attempting to deal with? In this, we've also found very inaccurate modeling or assumptions. So we went in Cleveland, for example, looking at asthma, and they understood where part of an area was in a particularly low-income African-American community, but they were missing other areas that were, in fact, hotspots with high incidence. This is a Southern California map, not Cleveland, of course. But it's showing multiple areas. So we can use this to map hotspots of a health problem. We can use it to map hotspots of health literacy. And we can also use this information, as it's done on the right, to look at what's the density of the population. Where are the most cases? Where would you need to intervene if you want to move the average needle? Or how do you make a good choice in picking where to start? We can then use the information to help diagnose a hotspot. What I usually talk to people about here is that odds ratios, which is what we produce on the science side, only make your heart go pity-pat if you produce odds ratios for a living. The rest of the world doesn't know what to do with that information. Or care. It's just not exciting. What's a 1.5 anyway? So it's important to be able to translate things into tests, results, into data that individuals can read. So we spend a lot of time in the health literacy work thinking about how do we get patients to be able to read things. We need to think about how do we get stakeholders and decision makers able to read things. And maps are one way that we can take a lot of complex information and put it out in such a way that I can give it to someone and they can understand where the problem is. They know how to read it. It's the same as being able to understand reading another test or reading other health advice. So I want to take Rima's definition of policy and communication and say we need to use that and inform our work at multiple levels. The other thing that matters is when I get together a group of decision makers, they all come in with their own intellectual priors as hypotheses as to what's going on. They may not think of it as hypotheses, they may think of it as, I know what's going on. But if I want to be effective in bringing a group together to deal with health literacy problem, to deal with how it's going to be useful, then I need to be able to not just come in and say, I know the answer, and it's figure 2C. I need to be able to come in and say, we can look at these different hypotheses, and I can put up the map of the problem, and I can put up a map and say, did it map onto poverty? No, I guess we can agree it's not fully mapping onto poverty. Did it map onto linguistic isolation? Actually, that looks like it's more of a problem in this local area where you're dealing with. We need not just to be able to give them information that's the academic information that's generalizable to other areas, but to address what's going on in their area of purview and how can they read and use the information effectively. Missing information, not having a good understanding of where a hot spot of a problem is and not having a good information of where problems of health literacy are can mean ineffective interventions. It can mean we don't produce results. And in many of the worst cases, it can mean we do a little bit of good, and when we do it, we make a disparity worse. Because the most advantaged groups will still benefit from your wonderful infographics or other information that goes over how to prepare for this test or how to make this decision. But if your intention is to go in and help the most disadvantaged group, then you need to understand and not do what happened in this case. And unfortunately, I could give you slide after slide of different studies where we find this, where the targeted areas were, in fact, these blue outlined intervention areas, and they weren't targeted and focused in properly on where the problems were the most serious. They didn't go in with the kinds of information that would tell them where they would have the biggest bang for the buck. And as a result, well-intentioned people go in with an intervention that we know can have a reasonable return on investment and be worthwhile to the organizations doing it. And they failed to show that benefit, and they failed to serve the disadvantaged communities. So I would like to see us using different kinds of mapping to target research much more standardly, to target the interventions much more standardly, and be able to have the impacts that are possible so we can start to show gains and actually help the people who are trying to make a difference in different organizations have those gains so they can go on and disseminate further. So what will mapping enable you to do? It'll help you identify the areas and topics that are a priority for an intervention, bring the partners to the table for collaboration, really be able to communicate with them and address their concerns and assumptions about what's going on, and increase the return on investment of the interventions that people agree to undertake and take on. Moreover, it can help us select appropriate interventions and be sure that they're targeted effectively so we can make a difference with the groups that we are by far the most concerned about. I'm happy to take questions afterwards, but thank you.